Good morning, everybody. Nice to see you all bright and early again. Sorry I was a couple of minutes late, and that exam sign threw me off a bit on the front door there. So today and tomorrow we're going to be looking at mammography. Today I guess is more about the clinical background, and we'll just finish with looking a little bit about the X-ray spectrum used for mammography and how in particular that differs from the X-ray spectrum that we'd use in general radiology. And then tomorrow we'll focus more on the equipment itself and some of the advanced applications. Can everyone hear me okay? Cool, lovely. So we'll start just by looking at breast cancer as a disease, the sort of factors that might put you at higher risk of developing cancer, look a little bit at the anatomy of the breast, those sorts of things. So breast cancer then is a disease in which the abnormal cells in the breast tissues multiply and form an invasive or malignant tumour. It's a very complex disease. At least 6 different types of breast cancer have been identified. And the key issue we have is with invasive breast cancer, because once it becomes invasive, it can spread to the lymph nodes and it can metastasize. And that's what makes it such a potentially dangerous disease, and why it's so important then to capture it early when the cancers are very small and still contained within the breast. So this is the issue then, that the tumours can invade and damage the tissue around them and spread to other parts of the body through the lymphatic or vascular system. So obviously your breast is very close to your sort of axilla armpit area, and that's where the lymph nodes are, and that then is where the cancerous tissue can start to spread. And if the spread of the tumours is not controlled, then they can result in death. But actually, generally speaking, the survival rate from breast cancer is very good. So not all tumours are invasive. Some are benign, that are not life-threatening, whereas others are called in situ lesions because they're contained in the milk ducts and have not invaded the surrounding tissue. So those cancers are what we call DCIS, or ductal carcinoma in situ. And critics of the breast screening program often comment on the fact that breast screening detects an enormous amount of DCIS, and while it's in situ, it doesn't actually do you any harm. But it's still a form of cancer, and it's still an indication of something that can potentially become invasive. So even if you're diagnosed with DCIS, we still have to take the follow-up steps to try and remove that or have follow-up treatment. Even though it might never go on to do you harm, we can't predict which women it will actually go on to become invasive in. So it's still very important to pick up DCIS as well. Now, breast cancer is a very common cancer, particularly in women, although it can affect men as well. Within Australia, breast cancer accounts for 28% of all cancers in women, 16% of all cancer deaths, and about 1 in 8 women will develop breast cancer over their lifetime. Now, although much research has been conducted into all aspects of the disease, there's still no clear answer as to the cause of breast cancer, and as yet no means for preventing the disease. So the best we can do to reduce mortality then is to have early detection, because that greatly improves the survival rate then. So if we just look at the percentage of all female cancers then within Australia, the pink columns are the percentage diagnosed. So breast is by far the most common cancer in women, but it's not the most deadly cancer. Even though quite a high rate is diagnosed, the percentage of cancer deaths from the disease is relatively low in comparison, compared to looking at lung cancer, for example. Although it represents a fairly small proportion of all cancers, then as a percentage of cancer deaths, unfortunately, it represents a much higher proportion then. So breast cancer is far more treatable than lung cancer, for example. As I say, about 1 in 8 women will develop breast cancer over their lifetime, but there are risk factors for breast cancer, and there are some women whose lifestyle factors or genetic makeup are going to make them more susceptible to the disease than others. So certainly the biggest risk factor is age. And what's in the middle column then is relative risk. So it's sort of the risk of an elderly person compared to a young person. So somebody in their 60s or 70s, for example, is about 10 times more likely to develop breast cancer than somebody maybe in their 20s or 30s. Geographical location is an unusual one. You are at much higher risk of developing breast cancer if you live in a developed country compared to a developing country. The reason for that may be linked to the other factors, in particular things like the age at which we tend to have our first child in the developed world, the number of children we might be having. But there may also be some bias in that statistic, because what we see as well is you tend to see more breast cancer being diagnosed in wealthy populations compared to low socioeconomic status populations. And the reason for that is they are the women who are probably more likely to attend for breast screening. So it may not be that we're particularly at higher risk in developed countries. It may just be that we have screening programs so that we are diagnosing more cancer. Breast density is an interesting one, and it's been a pretty hot topic for quite a few years now. People have developed breast density software. People are taking follow-up action if a woman is diagnosed as having high breast density. Generally speaking, a woman with very dense breasts is about 4 to 6 times more likely to get breast cancer than a woman with very fatty breasts. What we don't know as yet is why some women have very dense breasts and others don't. And it was the topic of my PhD, and people have been researching it since the 70s, still with no clear answers. But it is a very high risk factor for breast density. Mammograms are not very good at diagnosing cancer in dense breasts because the tissue just appears as a big cloud of white. So if high breast density has been diagnosed, then women are often suggested that they go for MRI or ultrasound as a follow-up. The other factors tend to be sort of hormonal related. It's more to do with how long within your lifetime you're exposed to estrogen. So things like when you start your period and then have menopause, age at first full pregnancy, those sorts of things all have an underlying hormonal influence. Family history, sadly, is a fairly high risk factor then. People with breast cancer in a first-degree relative are twice as likely to develop the disease. Body mass index does have an impact, as it actually does on pretty much all cancers then. Generally speaking, the higher your BMI, the more susceptible you are to developing cancer. HRT, again, another sort of hormone exposure factor then, will increase your risk. Alcohol consumption is a fairly small risk. And something I haven't put in this table is genetic factors. So you might have heard of the BRCA1 gene and the BRCA2 gene. Women who carry those gene mutations, I think, have about an 80% chance of developing breast cancer. So rather sadly for them, it's almost guaranteed to happen. And you probably heard about Angelina Jolie several years ago, decided to have a mastectomy to prevent her developing breast cancer because she was one of those gene mutation carriers. Now, as a population risk factor, it's very low because so few women actually carry that gene mutation. But sadly, if you do carry it, your risk of developing the disease is very, very high indeed. So what predicts a poor prognosis then? Well, features associated with a less favourable outcome will include larger breast cancer size. So obviously we need to be detecting the cancers early. The presence of cancer in the nearby lymph nodes, which we'd call positive nodes, because that then demonstrates evidence of spread. The cancers become invasive. Once it can metastasize through the body, it becomes increasingly difficult to treat. And then following on from that, the number of positive nodes as well. So because of those issues, early detection is very important. There's currently no means of preventing breast cancer, and I'd be very surprised if there ever was, to be honest. So really what we need to do is put our focus on reducing deaths from the disease. And the way we've done that then has been on finding breast cancer as early as possible. So the aim of a screening program is to detect invasive breast cancers while they are small and before they've spread beyond the breast. And if we're able to do that, then early detection of cancer at the localized stage greatly increases the 5-year survival rate. So this chart just shows why early detection is so important then. If your cancer is localized, so it's still sort of contained within the breast, then you've got a 98% chance of 5-year survival, which is very good. Whereas by the time it's become distant, it's spread to the lymph nodes, it's possibly metastasized throughout the body. Sadly, the 5-year survival rate has dropped to only 24%. So we'll look now at mammography. What is it? People often just say it's any form of sort of breast imaging, but strictly speaking, the term mammography does refer to the X-ray examination of the breast, which obviously we're doing to determine if abnormalities, including cancers, exist. It's thought of predominantly, you probably link it with breast screen, but it can also be used as a diagnostic tool. So if a woman has presented to her GP with what she suspects is a breast lump, she'll be referred on to mammography as the first port of call, and they'll use that then to diagnose whether that's the case. So this is just a few diagrams then of mammography. This, I suspect you probably haven't been into a breast screening practice. You probably don't do placements in breast screen at this stage of your training. So you may not have actually seen the X-ray unit. We do use dedicated equipment. You can't just do it on any old X-ray unit. So this is what the equipment looks like. This is the Siemens model then. So we have a gantry then, we have a breast support platform here, so the woman will lean into the breast support platform and will have her breast compressed, and that's quite a painful part of the procedure actually, and it does prevent women from returning for their second screening appointment. So the breast will be positioned, we have an X-ray tube up here, the focus to image distance is fixed, you have a choice of multiple field sizes, and then you just take an X-ray image and a couple of projections. We only need a very small control panel. The energies used in mammography are very low. The amount of scatter being generated by the breast is fairly small. So protection from the operator, we still need a little bit of lead glass, but not as much as we would in general or CT, for example. So that's the equipment there. Siemens have like flashing lights at the back. It goes from pink to green to gold to try and calm the woman down as the radiographer applies about 20 kilograms of force to her breast. So it really is not a hugely pleasant exam to undergo. This is just showing it schematically then. So at the top we have the components of the X-ray tube. What we have that's absolutely vital is the compression plate. Then we have what we call the breast support platform. And under that then will be the detector. So there will be a grid and a detector under that. And I'll cover all of those components in more detail tomorrow. So we'll look at mammography first of all with regards to screening. The purpose of screening is to reduce illness and death resulting from breast cancer. It's to detect cases of unsuspected breast cancer in women, enabling intervention at an early stage. So Breast Screen puts leaflets out in GP practices and various locations, and it says that if you attend for breast screening, you can detect a cancer the size of a pea. If you do self-examination, you can only detect a cancer the size of a cherry. So it's a fairly big difference in size, and that difference could potentially save your life if you catch it at the very early stage. So finding breast cancer early does mean then that the cancer is small, and as we've seen, that's associated with increased treatment options and improved survival. Now, Breast Screen Australia targets women aged 50 to 74 to attend for their mammograms every 2 years, but women aged 40 or above are also eligible to attend. So from the age of 40, you can ring up and request an appointment, and from the age of 75, you can phone up and continue to request appointments. I mean, the reason that age range has been chosen, number one, that is the age range in which we would expect the most cancers to be detected. As I say, cancer is generally a disease of older people. Another reason we choose that age range is because breast composition changes over age. So as you get older, your breast becomes increasingly fatty. In your 20s and 30s, your breast will be very dense, and to take an X-ray image of a dense breast is going to give you a very poor image. So mammography would be unlikely to detect breast cancer in very young women anyway. So that's the reason that we go for that slightly older age range there. What this graph is showing is the benefits of breast screening, and this is from UK data then. So what we've seen, the dark pink line then, and if you work in breast screen, you just get sick of seeing pink everywhere. But what it's showing is the incidence rate over time. So from 1975 to, it's quite an old graph now, to 2008. What we see is that the incidence of breast cancer is just increasing. And the reasons for that then, well, probably we've got an increasingly aging population. We talk about the generation called the baby boomers, and you know, by the sort of 90s to 2000s, they will have reached the age whereby they will be presenting for breast screening. So there's a big population of women of a certain age in which cancer will be detected. But what we also see over time is that our lifestyle has changed in a way that's making cancer incidence increase. Some are good things. We're all living older, which is nice, but unfortunately, age is the #1 risk factor for cancers of any type. Other things that are changing are the age at which we first have children, the number of children that we have, things like that. And they're going in a sort of negative way to affect our risk then. So having children later, having no children, or having fewer children are things that will increase our risk of breast cancer. Also things like gaining a lot of weight over sort of middle age as well is another risk factor. So, as I say, what we've seen over the years is that the incidence is continuing to rise. However, what is positive is that the number of deaths is dropping. So the gap is widening between the incidence and the mortality then. And really, what this graph is showing is that's largely attributed to breast screening then. Breast screening was introduced in the UK in 1988. That also explains this big jump in the incidence. There was probably quite a pool of cancers that had previously gone undiagnosed, and they were detected at screening. But since the introduction of breast cancer, we've gone from mortality remaining fairly stable to actually decreasing now. So I certainly support breast screening. You can read plenty in the literature of people who don't, who think it's a waste of money. But my interpretation of the evidence is that it's a very good thing. This really is showing the same sort of thing, just with Australian data. Breast Screen Australia was launched in 1991. And again, it's showing much the same sort of thing then. This is showing the number of deaths, which is fluctuating a little, but what we have to take into account, as I say, is this sort of baby boomer population, an increasingly aging population, so that when we standardize the number of deaths by age, again, we see the same thing. Since the introduction of screening, we've seen a continuing reduction in mortality then. So I think, you know, that there's a lot to show that breast screening is a very positive thing. Moving on to what happens when you attend for screening mammography then, what will happen is that 2 complementary views of each compressed breast are taken. One is called the CC view, which is the craniocaudal view, which basically means the x-rays come in the direction from your head to your feet. Then we have the mediolateral oblique, or the MLO projection. That's taken from an oblique or angled view, which is typically about 45 to 50 degrees then. So the x-rays will actually become, you'll rotate the x-ray tube and the x-rays will be coming in like this. So from your middle section out to the lateral section at an angle of about 45 to 50 degrees. Now, once upon a time, screening would only comprise one view, and that was the MLO view. And that's probably the best view, because what you actually capture on that view is you capture a little bit of the axilla, or sort of the armpit area. So then you can potentially see any lymph node involvement, you can see any spread to that area then. However, doing the CC view as well has improved sensitivity, so it's improved the detection rate. And when you do the CC view, it just adds that extra sort of element. It gives the radiologist a little more confidence then. So 2 views are now done routinely. And this is what the CC view would be then. Obviously, you'd have your X-ray tube up here. They'd come in this direction from head to foot then. They take an image of the compressed breast. And this is typically what you'd sort of get, a little bit of glandular tissue within the center of the breast, with the periphery being predominantly fat. And these are what mammogram images look like then. So they sort of follow that glandular tissue distribution within the central portion, and then as we come out to the skin edge, the sort of peripheral region then tends to be a little more fatty then. And what you see as well actually is that the pattern within the breast is often fairly symmetrical. And if it's, I mean, obviously not a mirror image, but you tend to see similar distributions of glandular and fatty tissue. And if you don't, or, you know, if you were to see a bright area here and not here, or a sort of spiky area here and not here, that asymmetry can actually be used to guide the radiologist to sort of point out that something might be a little suspicious. This is the MLO view, and as I say, it's preferred because we can sort of get that extra axillary area, and what we can get is when we do the view, the breast is able to be pulled a little more onto the breast support platform, so that we're actually visualizing the tissue all the way to the pectoral muscle as well. So that would be the MLO. So you're just getting a little bit more breast tissue within the image then, and that would be viewed in conjunction with the CC view for the radiologist to make their diagnosis. Now, screening mammography alone can't prove that an abnormal area is cancerous. All it will do is raise a suspicion of cancer. And if that's the case, then the woman will be recalled for diagnostic breast imaging. Diagnostic mammography will also be used to determine if cancer is present in a woman with symptoms, such as a breast lump, for example. And once a woman presents for a diagnosis, then we've gone beyond merely looking for something suspicious to actually trying to find the exact size and location of the breast abnormality, to image the surrounding tissue and lymph nodes, because probably what the diagnostic mammography is going to do is then inform the decision to maybe go for surgery or radiotherapy or whatever course of action might be required. So often when a woman presents for diagnosis, then we don't just repeat the mammogram, we'll do some extra views. And one of those views is called spot compression, and what it is it's a compression paddle with a little sort of indent in it, and what that indent does is it applies even more pressure, as if 20 kilograms is not enough. That little tiny area applies a huge amount of pressure to the area where the suspicious area has been seen, and so it just spreads the tissue a little bit more to guide whether there might be something abnormal within there. What we might also do, particularly if we're looking for the DCIS form of cancer, which actually presents as lots of little specks of calcium, is we might do a magnification view to get a better image of those, get better spatial resolution within the image. So what will be done in that case then, the radiographer will clip this magnification stand onto the mammography system. The breast will be positioned up here instead of down here, which is what we'd call contact mammography. Obviously we get more X-ray beam divergence and we get a magnified image as a result of that. So it enables us to see the cancers enlarged, and that's, as I say, particularly useful when we're looking for the microcalcifications. X-ray imaging is not perfect by any means, and as I've already said, it's not really very good in women with dense breasts. So what might happen then is the woman might be referred on for supplemental imaging, one of which would be ultrasound. Ultrasound is very good for distinguishing cysts from masses. So there are forms of breast lumps like fibroadenomas which are benign, and ultrasound can show that very clearly. It can show the shape of them probably much more clearly than the X-ray image can. Breast MRI is very good for women with breast implants or for women with increased radiosensitivity, so young women, women with the BRCA1 or BRCA2 gene mutations then. So women, obviously the younger you are, as we looked at in my first lecture here, you know, the longer the latency period you have, the more proliferation of tissue, the more susceptible you are to the effects of radiation. And that's actually true for the BRCA1 and BRCA2 gene carriers then. So in those groups of women, we don't want to be giving them lots of X-ray imaging because we run the risk of inducing cancer as well. So they tend to get referred for MRI. And as I've said as well, women with dense breasts, MRI doesn't rely on attenuation in the same way that X-ray imaging does, so you get a much better image. One thing MRI can do, which is quite clever, is it can do contrast-enhanced imaging. So what you find, again, to determine what might be a benign mass from a tumorous mass then, is you can look at the blood supply to that mass. And tumours tend to take up the blood very quickly and wash it out very quickly as well. So if you can inject contrast agent to mimic what the blood is doing, you can plot these sort of wash-in, wash-out curves then, and it will give you an added indication of whether something might be malignant then. So recognition of breast cancer depends on detection of subtle architectural distortion, so just things within the breast that don't look quite as they should. But predominantly what we're looking for is masses, and unfortunately the density of a mass, whether it's benign or malignant, is not really much different to the density of surrounding tissue, particularly if that tissue is quite dense. So there's no issue from a spatial resolution perspective of detecting carcinoma. Generally speaking, they might be about 5 millimeters to 10 millimeters in size, but what makes them very hard is the contrast in the image that's required to separate them from surrounding tissue. What we're also looking for is what's called microcalcifications, and that's what we sometimes refer to as the DCIS, the ductal carcinoma in situ. What these are, they look like lots of little speckles. They're calcium compounds of a relatively high atomic number and density, so they will have a high inherent and subject contrast, although the fact that they're very small, again, makes the contrast quite low, even though they have high atomic number. The main issue, though, with being able to detect them, though, is that they're very small in size, ranging from as low as 10 micrometers through to several millimeters. And another indication of breast disease might be skin thickening as well. But the key ones are these two, the masses and the microcalcifications. Now, once a woman's come for screening, she's come from diagnosis, they really do want to know if she does have malignant tissue within her breast. Unfortunately, the only definitive way to define that is to actually take a sample of that tissue and send it off for pathology analysis. I said screening mammography is quite unpleasant. I don't even want to think how horrible it is to go for a breast biopsy. It looks like a body piercing needle, but is probably about twice as thick because we do need to take a little sort of cylinder of tissue from the breast then. So we call them core biopsies. We line up, essentially it's called a gun, with a very long needle in line with the area of suspicion. That gets fired through the breast tissue and retracted, and it brings with it a little cylinder of tissue that can be sent off to pathology. So with it being so unpleasant, often it's done with the woman lying prone on a biopsy table because the pain can cause them to faint, sadly. So the breast drops through this hole here and then you can't see what's going on, and if you feel like fainting, at least you're lying down. So it's not a pleasant procedure, but it is really the necessary step to take to actually acquire a tissue sample. So challenges of breast imaging then. We'll look at the anatomy and I guess a little bit of physics. Just finishing off in this session, we'll look at the X-ray spectrum, and then tomorrow we'll look at the equipment design itself. So Helen gave me these slides a few years ago, and I have modified them and added some things to them because I've been working in mammography for about 15 years. And when she sent me her slides, I thought, why on earth is this in here? So obviously Google is your friend, and I looked up why it is, and apparently this was thought to be maybe a very early depiction of breast cancer, maybe not necessarily the artist's intention, but people looking at the breasts of this woman very closely spotted that the underside of the breast was blue and there was swelling under the armpit, and it's led some people to question whether she actually had breast cancer. So it's not a new disease by any means. I think that was probably why this picture was in here. But 1654 is early enough, but in actual fact, even Egyptian hieroglyphics and carvings have shown, I mean, obviously they're not photos, but they have shown images depicting, in this case, what may have been a mastectomy, or sort of even Aboriginal early artwork shows images that people have interpreted as showing swollen lymph nodes and things like that. So, you know, it's a disease that's been around for a long time, even though it may not have been given the term breast cancer, for example. If we look at breast composition, really, I mean, I am a physicist, so I will call the breast either glandular tissue or fat. I like to keep it simple. The glandular tissue looks white on the image, the fat looks dark, and that's my level of understanding doesn't go greatly beyond that, to be honest. What the breast actually is a mass of glandular, fatty and fibrous tissues positioned over the pectoral muscles of the chest wall and attached to the wall by fibrous strands called the Cooper's ligaments then. So these are the Cooper's ligaments around the edge then, and then we've got a mix of sort of fat, gland, vasculature, milk ducts, those sorts of things. And so what we do see is that always, as I said before, there is this sort of peripheral layer of fat around the breast then, and then within the centre is some form on some level of fibroglandular tissue then. How do these structures appear on the mammogram? Well, you can probably work it out based on their density then. Breast masses, including both non-cancerous and cancerous lesions, appear as white regions. Fat obviously appears as black, it's far less attenuating. And then all other components of the breast, the glands, the connective tissue, tumours, calcium deposits, will appear as various shades of sort of grey to white on the mammogram. So we'll have a look at that now, and every breast will appear completely different on a mammogram, and actually what has a huge impact is the processing applied to the images as well by the vendor. So you could, I don't think I have it in my talk, but one of my colleagues has been for screening mammograms for several years and has had mammograms taken on 3 different machines, and even for the same breast in a short space of time, the image is quite different. So what can sort of make or break a company breaking into the mammography market is how they process their images, because the radiologists have a very particular view about how they like the images to present, whether they like them very black and white or whether they like that sort of greyish film style appearance. So this would be a mammogram then, and then I've sort of just highlighted some of the main components then. So we'd certainly have the pectoral muscle here, fairly obviously. This would obviously be the region of fibroglandular tissue. This looks like quite a dense area, but as a percentage of the whole breast, it's maybe only, I don't know, about 50% dense. Obviously, you can see the vasculature quite clearly within the breast. What we see sometimes is what we sometimes call like this orange peel effect, and we get like a bit of skin dimpling due to compression, so the pores in the skin, once they're compressed, you can even see the X-ray appearance of that. And then this would be a different breast on a different vendor. So you can see straight away, it looks a bit more smoothed, it looks a bit more grey compared to this one, which is very sharp, very black and white. Again, what you can see really, the sorts of things, we've got this region of mixed fibroglandular and fatty tissue. It's probably not quite as bright as this area here, so this is probably a slightly less dense breast. We see these sort of scalloped edges, these sort of curvy edges there, and that would be the sort of Cooper's ligaments then around there. Obviously, we've got that peripheral layer of fat then. And what you can see on digital mammography that you couldn't see on film is you can see the skin edge as well on the images. Breast composition with age, then, as I've alluded to, it does change. So in infancy, the breast is composed primarily of adipose, i.e. fatty tissues. And then at puberty, the fibroglandular tissue begins to develop, and this development continues until maturity. So again, this probably comes back to these sort of hormonal factors. At puberty, that's when you start to get exposed to estrogen, or estrogen being produced within your body when you start your period, and that then is when the fibroglandular tissue starts to appear. So obviously, if you have a very long period between starting your period and reaching menopause, then you have all of that time in which your body is exposed to estrogen. That's sort of keeping the fibroglandular tissue going, and that's maybe then why you have that increased risk of breast cancer, and maybe why the high breast density link comes in as well. However, as you continue to age, then the fibroglandular tissue starts to be replaced by fat again. So in general, the younger the women, the denser her breasts will be. As a woman ages, her breasts become less dense, and it's usually easier for radiologists to detect breast cancer in older women, hence the reason that we have screening from ages of 50 upwards. Now, even though this is the rule of thumb, you do see wide variations of radiographic density in the breasts of women of similar age. Composition and size of the female breast, again, these will vary widely, and these are all just factors that make mammography very challenging indeed. The compressed breasts can have thickness of up to about 12 centimetres, with a median value of about 6 centimetres in the Australian screening population. I've been in Australia almost 10 years, and I've seen the launch of breast screening going digital in a number of states throughout Australia. And we did buy an equipment vendor from Scandinavia. They actually had to modify their equipment for the Australian market because it could only accept breasts up to about 8 centimetres thickness. So again, there are certain areas within Australia and certain demographics of women where breast screening is just very, very challenging indeed. The area of the breast can be as small as 35 centimetres squared, or so large that the breast won't fit on a single image, and you've got to do multiple exposures then to cover the whole breast, even on a 24 by 30 centimetre detector. And obviously breast density and glandularity can vary greatly as well. So the mammographic image itself, we've already seen a few examples. Basically, the structures of their breast and their differential absorption are what control the contrast of a mammogram. One of the key differences between mammography and general radiography is that images result from the difference between X-rays absorbed by the photoelectric interaction and those that pass through the breast as image-forming radiation. So I think by now you've had your interactions lecture, and what you see is that basically what we're looking for to generate an X-ray image is attenuation. And attenuation is equal to absorption plus scatter. Absorption is the dominant effect below about sort of 25 to 30 keV in soft tissue, and once you go beyond that energy range, then Compton scatter becomes the predominant effect and the predominant contributor to attenuation. So in general radiography, it's scatter that's the predominant interaction that gives us attenuation in an image. In mammography, where we're looking at much lower energies, it's photoelectric absorption that's the predominant contributor to the image then. Now, the different absorption and attenuation depend on a number of factors. The first will be the density of the tissue. The second is the atomic number of atoms in the tissue, and that's quite a key effect in the photoelectric absorption interaction. The thickness of the breast will have an effect, and the X-ray energy will have an effect as well. So with all of that information in mind then, I've got an example just showing how challenging breast imaging really can be, and the area highlighted with the circle does actually have a cancer there. The small differences in attenuation of X-rays between normal and malignant tissue result in very low subject contrast and make cancer detection very difficult. And in fact, there is an expression that finding a breast mass in a mammogram is like finding a snowball in a blizzard. And obviously, I'm not a breast radiologist and never will be, but to my untrained eye, I really cannot see anything within this circle that looks any different to anything in the surrounding tissue there. You can see this is a very dense breast. We have a huge area of that sort of brighter tissue within the middle there. It's a little sort of mottled. It's a mix of dense and fatty tissue, but on the whole, it's quite a bright area. Now, it is possible that a radiologist didn't pick up a cancer in the CC view. And so I've got all the examples here. This is why doing two views in conjunction can be quite beneficial then, because when you look on the MLO view, it looks slightly different. It has a slightly different structure then within that circle that you're certainly not seeing here. Now, what I'll talk about tomorrow is something called tomosynthesis. It's a little bit like CT in that the X-ray tube moves around the breast. It doesn't do a whole 360-degree rotation, but it moves by about 15 degrees. And that's enough then to be able to reconstruct all of those projection images into slices through the breast. And once we do that, we start to lose this superimposition of dense tissue overlying cancerous tissue. And you can see then on this tomosynthesis image then, there's definitely something abnormal within that slice of breast tissue there. Now, I've talked a bit about breast density. This really is a huge challenge of mammography as a form of imaging. It's much harder to detect breast masses if the breast is very dense. The overall sensitivity of mammography is about 80 to 85%. So even at screening, we're still missing cancer in 15 to 20% of the screening population. So it's far from perfect, but it is actually the best modality that we have. The problem we have, though, is that sensitivity decreases with increasing breast density. So this was a study done where they looked at breast cancer diagnosis and compared it to the density category of the breast. So this one is very fatty, this one is very dense. And what they found is that the sensitivity, so the percentage of cancers they were able to detect in breasts that looked like this, was 94%. It was almost all of them. And then it dropped off as the breast became more dense, to the point where in women who had breasts like this with a very large area of dense tissue, they were only detecting 1 in 2 cancers in women who had such dense breasts then. That's why over the years there's been a drive now for breast density to be recorded and for those women to be offered follow-up ultrasounds, follow-up MRIs, and just generally to be informed that mammography is not the best modality for them. They're also at higher risk and they may need to look at other strategies. We've looked a bit about breast masses. We'll look a little bit at calcifications now then. So these again, as I said, are like the DCIS, the ductal carcinoma in situ. They're little calcium compounds contained within the milk ducts generally. The reason these are so hard to detect is because of their very small dimensions, might be as small as 1/100th of a millimeter. Here you probably can't see them, but by the time we've magnified, whether we do electronic magnification or do a magnification view in mammography with geometric magnification, I think you can start to see the sort of speckles there. So for that reason then, the mammography system needs very high spatial resolution. On the plus point, microcalcifications often appear in a cluster, which can make detection easier. So you're not looking for a single speck. If you have a single speck, it's probably dust on your image. You're looking for a cluster of them. Now, microcalcifications do have a high atomic number. The atomic number of calcium is much higher than the atomic number of the atoms in soft tissue. So what that means is they are likely to absorb X-ray photons. The probability of absorption is going to be very high in the microcalcifications. And hopefully you've remembered this from your interactions lecture, that the probability of photoelectric absorption occurring is proportional to Z cubed over E cubed. So we get the most absorption in very high atomic number materials, like bone, for example, and we also get the most absorption when X-ray energy is low, which it is in mammography then. So we get a lot of absorption within the calcium of the microcalcifications. Saying that, though, they are very small. I mean, they might be 1/100 of a millimeter in diameter, and that would be the thickness of them as well. So overall, they're not very attenuating simply because they're so small. So again, that can cause low subject contrast. And another issue we have is that if the image is very noisy, so by noise, I'm sure you're familiar with that sort of speckled or grainy appearance, that can make it harder to detect microcalcifications. So not only is the resolution an issue, the contrast is an issue, and the noise within the image is an issue as well. So it's all three image quality parameters that have to be really good in mammography. Now, obviously, this is just noise within a piece of perspex, but that's that sort of speckly appearance. And I'm sure you can imagine that if you're trying to look for little white specks like this, and this is your background, it's going to be very, very hard to detect them. Dust and talc can also mimic microcalcification, so it's very important to keep your mammography equipment clean, because this is how dust presents. And then talc, which obviously is a calcium-based material, can also present as little specks like that. And you know, talc is very commonly used amongst the women of screening age, and so often when they come for breast screening, they're advised just to wipe off any deodorant and any talc that they might have put on that morning. So what are the important image quality parameters then? Well, as we've shown from those challenges, we need really good contrast in the system because of the need to see small differences in soft tissue density. We need really good sharpness or really high spatial resolution because of the need to see small calcifications. We need very low noise within our image because that will affect the visibility of very subtle microcalcifications. And we need to achieve all of these things at a very low breast absorbed dose because mammography is predominantly used for screening, which means we're predominantly irradiating a healthy population, and there is a subsequent risk of radiation-induced breast cancer from mammography. So it's pretty hard to achieve all those things. Now I put this question in, how many breast cancers are detected at screening? I wouldn't really expect anyone to know, and you'll probably be surprised how low it is. Even though over a lifetime 1 in 8 women develop breast cancer, within an individual screening round, they only detect about 7 breast cancers per 1,000 women screened. So, you know, that's less than 1% of the population at the time of their screening appointment will actually have a breast cancer detected. So, you know, that really is more than 99% of that screening population are disease-free. And so that's why it's so important to keep the breast absorbed dose as low as we can, but while making sure, number one, that we do meet all of these image quality requirements. We'll start to look a little bit at the physics now, I suppose. Just following on really from the challenges of imaging masses within a background of fibrous tissue then, if we look at the density of carcinoma versus fibrous tissue, we can see that it's almost the same. Fatty tissue is much lower, which is why it's much easier to detect breast masses on a background of fatty tissue. And then if we look at the linear attenuation coefficient at 20 keV, for example, again, it's very, very close for carcinoma versus fibrous tissue. Again, fat is much lower, so the contrast between carcinoma and fat will be pretty obvious then. So what we're seeing then is, you know, these two lines of attenuation. So this is attenuation of carcinoma, fibrous tissue, and fat. These two are almost overlapping really, and certainly by the time we've gone above sort of 30, 35 kV, they're the same. So we really want to maximize that difference, even though it's a small difference. And that's why we're sort of aiming for an X-ray beam energy round about 20 keV in mammography. It's just, you know, it's soft tissue imaging. We've got similar linear attenuation coefficients, but we can maximize the difference in attenuation if we work at low energies then. And again, this is showing much the same thing. We've got the tumours of different sizes. So if the tumour is a little bigger, it will have more contrast. It will be easier to see. Calcifications are far less of an issue because they naturally have that high atomic number, high absorption then. So we don't worry too much about the calcifications in terms of contrast. But again, just looking at the subject contrast, so this is tumours compared to fibrous tissue. Again, what you see is you get a bigger difference in contrast the lower the energy. So again, that sort of supports why we're working around about 20 keV as our X-ray energy then. We'll just revisit the photoelectric effect then. I have said some of this already, but as you know, the two most important interactions for X-rays of diagnostic energy are the photoelectric effect, which causes our absorption, and then the Compton effect, which is the scatter. And then overall attenuation is equal to absorption plus scatter. Now, although malignant breast tissue has a negligible physical density difference from fibrous tissue, it does have a higher effective atomic number. So by utilizing the photoelectric effect then, which has this Z cubed dependence, what that means is we're going to get a lot more absorption within the malignant tissue compared to the fibrous tissue. I say a lot, it's still the contrast is very low, but we're going to get more because of this Z cubed dependence then. So that's just another reason why we work at low energies, because obviously photoelectric absorption is inversely proportional to energy cubed. So by working at low energies, we're maximizing the probability of photoelectric absorption so that we can maximize the difference in contrast based on this Z cubed dependence of the atomic number of malignant tissue versus fibroglandular tissue. Okay, this is the last little section. I haven't put my watch on today. I should have got the time. 8:59. Okay, so we'll look now at the X-ray spectrum in digital mammography. So this section is quite hard actually, so I'll go through it slowly, and I'll just ask you questions and make sure you're familiar with the concepts leading up to it. So first of all, are you familiar with the X-ray spectrum as a concept and how it would appear in general radiology as your starting point? Yep, lovely. So really this is what we have in general radiology. Then let's say we've set 100 kVp at the control panel then. The maximum X-ray photon energy will be 100 keV then. What determines our low energy cutoff within any X-ray spectrum is how much filtration we've added to the beam. So how much aluminium is in the beam, for example, in general radiology. What we have on the spectrum, obviously the fact that it's a spectrum means a range. So we have a range of energies and different numbers of X-ray photons at the different energies then. What we have, this sort of portion here, is what we'd call the Bremsstrahlung or continuous spectrum then. And within that continuous spectrum, we see that most of our X-ray photons have an energy round about sort of a third to a half of the maximum. Then what we have as well are what we call the characteristic X-rays as well. And then they appear at characteristic or unique energies based on the binding energies of the atom, the tungsten atom in particular. So that's just revision of the tungsten X-ray spectrum for general radiography. Now, just looking at characteristic X-ray production then, just to quickly revise what it is. This isn't on your mammography exam, but it just sort of helps to explain the spectrum for mammography then. What happens within the X-ray tube then is we have X-rays coming in from the cathode. They interact with the atoms within the anode then. Based on those interactions, we either get heat generated, we get Bremsstrahlung radiation, or we get characteristic X-rays. So if an electron emitted from the cathode collides with a K-shell electron, which is the inner one, and has greater energy than the binding energy, it will free that electron and it will leave a vacancy behind. So that K-shell electron is ejected then. What happens is that an electron from a shell further out, so one of lower binding energy, like the L shell, will drop in to fill that vacancy then. We get an energy difference between those two shells, and that energy difference then is emitted in the form of a characteristic X-ray photon then. So that's produced with energy equal to the difference between the two shells. Now in this particular example, our initial electron has knocked out a K-shell electron. So following this series of interactions then, what's produced is called a K-shell characteristic X-ray photon. What can happen, however, is that incoming electron can come in and it can knock out an L-shell electron as the starting point. And if that's the case, then you'd get an L-shell characteristic X-ray photon being produced if one dropped in from the M-shell or the N-shell, for example. So we always show it for the K-shell characteristic radiation, because if it was an L-shell interaction, the characteristic radiation produced would have an energy of about 10 keV, and by the time we've applied so much filtration to the beam, we've just eliminated all of those L-shell characteristic radiations then. Now, in mammography, given that we're not working at 100 kVp, we might be working at sort of 25 to 30 kVp then, we're not filtering the beam as heavily initially. We are then, on our initial unfiltered spectrum, going to see the L-shell characteristic radiation. And we don't want that. Just ignore the purple line for now. So we're not going to see any K-shell characteristic radiation because we're operating at maybe 30 keV, so we're not going to exceed the binding energy of the K-shell of tungsten, which is 69.5 keV. However, we are going to exceed the L-shell energy, which is why we see on the unfiltered spectrum these big characteristic peaks here then. Now, as I've said, we really want most of our X-ray photons to have an energy round about 20 keV. 10 really is too low. You're just going to get absorbed even within the fatty tissue of the breast. So we do need to get rid of these big characteristic peaks from the spectrum. So I think I've sort of said this already. So the unfiltered tungsten spectrum then, certainly when in mammography, it would have a high proportion of L-shell characteristic radiation at 8 to 12 keV. The reason being then the binding energy of the L-shell is much lower than the K-shell. It's only 11.5. We don't see those on the general X-ray spectrum because they're filtered out by the aluminium filters. And what we also need to do in mammography is filter them out. But we don't generally use aluminium as our filter material in mammography. We use different materials to achieve that. So just to revisit the purpose of filtration, certainly within general radiology, what it does is it removes the lowest energy X-rays from the beam. So really X-ray photons below about 10 keV, maybe even 15 keV in general radiology, are just going to be completely absorbed in the patient and not really going to contribute usefully to attenuation. So they're not going to improve image quality, and absorption just means absorbed dose within the patient then. So we have to get rid of the lowest energy ones, and that's true in mammography as well. However, in mammography, the filter material that we use has a special property which also significantly reduces the intensity of the higher energy radiation, thereby giving you a spectrum which is going to give you better contrast within the image. Basically, in mammography, if we could have not just a spectrum, but a single energy round about 20 keV, that's what we'd want. Monoenergetic radiation would be really nice, but we're never going to get that with the way X-rays are produced. But we use a filter material that gets rid of the low energy radiation and significantly reduces the high energy radiation as well. And so the materials that we use are called K-edge filters, and this again comes back to the photoelectric effect then. So we'll just, sorry to keep going back to things that you've studied already, but as I say, it's hard. I find it hard even now after working in the field for so long. So I'm trying to sort of build it up step by step so that hopefully it does make sense to you. So just to revise the photoelectric effect then, it's very similar to characteristic X-ray production, but the key difference is that it's not an incoming electron, it's an incoming X-ray photon in this case. So an incoming X-ray photon will come in. If that has energy greater than the K shell, for example, or greater than any binding energy of the shells, we'll go with K shell in this example, it will give all its energy to that K shell electron and remove it from the atom. Again, similar to characteristic X-ray production within the tube, an electron from the L shell will drop in to fill that vacancy, and we'll get characteristic X-ray photon emitted. Now, what's happened to this original incident photon is that it's been completely absorbed. It's given all of its energy to that K shell electron to be able to eject it. The absorption is what contributes to patient dose then. So it's gone, it's completely absorbed. It doesn't carry on doing any more interactions. Now, in order for the photoelectric absorption to occur, the first rule is that the incident X-ray photon must have an energy greater than the binding energy. And then we have this really weird rule that photoelectric absorption is most likely to occur when the photon energy and the electron binding energy are almost the same. So not only is it greater, but it's most likely to happen when it's only just greater. If the energy was far higher, it would be more likely to undergo a scatter interaction rather than an absorption interaction. So it's a very weird rule, but it underpins the phenomenon of what we call the K-edge. So just now looking at this graph then, I mean, generally speaking, and what's quite intuitive, I think, is that if you are to plot attenuation versus photon energy, attenuation will decrease with photon energy because as something becomes more energetic, it becomes more penetrating, it's more likely to get transmitted through the tissue. However, again, we go back to remembering that attenuation is equal to absorption plus scatter, and we know that photoelectric absorption is most likely to occur when the photon energy and the electron binding energy are almost the same. So this leads then to this strange sort of jump in attenuation at very specific energies for particular materials. So in mammography, we call these materials molybdenum, rhodium, and silver then. So what's happening is we've got our attenuation decreasing with energy until we reach a certain value, and this is the K shell binding energy value then. And at that value, we get a huge increase in the amount of absorption occurring, and more absorption means more attenuation. So that's why we get a great big increase in attenuation at this very specific energy, which we call the K-edge then. So there's that increased probability of X-rays being absorbed when their energy just exceeds the binding energy of K-shell electrons in the filter material. So 23 keV, for example, for rhodium. And that then is what causes the big jump in attenuation at the K-edge of the filter material. So remember, at this stage, we've generated our X-rays. We're now placing the filter between the X-ray tube before it actually reaches the patient. That's shaping the spectrum in a way to give us the most useful energy range that we can get then. So I hope this is all making sense. As I say, I do apologise. It is quite a difficult topic, and it does rely on you having a reasonable knowledge of the topics building up to it as well. So what happens then, again, going back to this original graph, the blue is the unfiltered tungsten spectrum. The dotted purple line shows the attenuation of the rhodium filter that would be caused then. Obviously, we need to have a lot of attenuation at this energy range to get rid of all of these L-shell characteristic radiations. We're going to get a little bit of attenuation round about here, then it will drop off, and then we'll get a lot of attenuation above 23 kV, and then it starts to drop off again with energy. So what the net result is then, if we now show the filtered tungsten spectrum for these different target filter combinations, and this is a key difference in mammography, you'll find on a single X-ray unit there will be multiple target filter combinations, whereas in general X-ray we're pretty much always working with tungsten and aluminium. So what will happen with, let's just look at the rhodium filter for example. Obviously, as with any filter material, we get a lot of attenuation at the low energy range, so we get rid of those undesirable low energy X-ray photons. And then what happens for rhodium is because it has a K edge at 23 kV, we get a huge amount of absorption at 23 kV, and then the amount of absorption just starts to decrease very slightly. Silver has a K edge at 25 kV, so again we get a huge amount of absorption at 25 kV, and then it allows a few more of the high energy photons to pass through. So we get we've gone from something like this, which has a huge range of energies then, to something like this, where the bulk of X-ray photons are going to have energy round about 20 kV, and the whole spectrum only contains X-ray photons from about sort of 12 to 25 kV in them. I hope that makes sense. So, I should have looked at my slides before. I think this is pretty much what I've just said. So just to go over that again then, the rhodium and silver filters, they've attenuated almost all X-ray photons with energy less than 10 kV, including the undesirable L-shell characteristic radiation. And what they've done, which doesn't happen in general radiology, is this particular filter that we use in mammography has significantly reduced the number of X-ray photons with energy above the K edge of the filter material. So above 23 kV for rhodium, above 25.5 kV for silver. Now I can't tell you what's going to be on the exam, but from memory some of the MCQs maybe ask you to try and remember these K edge energies. So I would try and remember those if you can, or at least ballpark figures. At least remember that in mammography, you know, we're aiming for bulk of X-ray photons around about 20 kV and K edges around about sort of 23 to 25. So the net result, and the reason we do this then, is that we get a spectrum with a narrow range of energies suitable for imaging soft tissue. Another key difference in mammography compared to general radiography is that general radiography, even if we just think of a chest X-ray, you know, we've got bone, we've got lung, we've got soft tissue. In mammography, all we have is soft tissue. Aluminium's unsuitable. It has a K edge of 1.6 kV, so that's why, you know, we don't get very much attenuation of these higher energy X-ray photons, and it doesn't have that same property then, and it's not generally used as a filter material in mammography. Now, half value layer that's the amount of material you'd need to put in the beam to reduce the intensity to half of its unattenuated value. It's a measure of sort of beam energy, beam penetrating power, that sort of thing. Even in mammography, we still would express that quantity in terms of millimeters of aluminium, even though aluminium's not the actual filter material. It would be rhodium or silver. The typical half-value layer, when we set 28 kVp, using either rhodium or silver, would be about 0.5 to 0.6 millimeters of aluminium. So if you add that much aluminium to the beam, you reduce the intensity to half of its value. For comparison, in general radiology, the HVL, when we set 80 kVp, for example, would be about 3 millimeters of aluminium. So obviously the beam in general radiology is a lot more penetrating, a lot more energetic than it is in mammography. In terms of what kVp that we set to get sort of the optimum spectrum then, generally your option in mammography is selecting something from about 25 to 38 kVp. So this will have an effect on the maximum energy of X-ray photons within the spectrum. Again, it's soft tissue imaging, so we do want to use low kVp. The advantage of doing that then is we will optimize contrast within the image. So low kVp equates to low KEV, i.e. low energy X-ray photons, which is what we need to get good contrast. If we go with low kVp, generally speaking, certainly what we want to achieve at the image receptor, i.e. the detector, we need a certain number of X-ray photons to get adequate signal-to-noise ratio within the image. So often the trade-off is that if we increase kVp, we can decrease MAS, and that sort of helps us achieve a reasonably low dose to the patient. In mammography, the fact that we're using low kVp and the fact that we need very low noise in the image does mean that we give a reasonably high MAS. For the average size breast, we'd probably be giving about 100 MAS. Now, for comparison, if you were to do an abdo-pelvis projection X-ray, you'd probably set something like 70 to 80 kVp and maybe 10 to 20 MAS. So you're using much higher energy, but then to compensate and keep dose low, you can use a low number of X-ray photons, so a low MAS. In mammography, we've got low kVp. The challenges of the image mean that we need very high signal-to-noise ratio or very low noise in the image. So low kVp has to be used in conjunction with pretty high MAS, so around about 100 MAS then. As a result of increasing MAS then, obviously the higher the MAS that you have to give, the higher the dose will be then. You don't need to remember these. Generally speaking, this would be a typical technique chart for mammography. So obviously as breast thickness increases then, what we'll do is we'll increase the kVp. And at some point, we will go from choosing the tungsten rhodium filter to choosing the tungsten silver filter, because that silver filter has the higher K edge. It allows a few more high energy X-ray photons to remain in the beam. So you don't need to remember the technique chart, but remember that we would increase kVp as breast thickness increased, and we'd also choose a filter with a higher K edge as we increased breast thickness as well. And that is it for today. So I'm sorry it's hard. Sorry, I am sorry that it's difficult, but I hope I've explained it well enough for you. But let me know if you've got any questions. Thanks very much. See you. Thank you. See you.